Please welcome Assistant Vice President for External Affairs at NCQA, Andy Reynolds.
Hello and welcome back. Welcome back in particular to our live stream audience, which is rejoining us for the second of two live stream sessions today. This discussion brings us back to that core or encompassing theme that defines NCQA's work and defines and permeates the conference, health equity. The title of the session says it all: no quality without equity. Our moderator is NCQA Director of Health Equity Initiatives, Dr. Brian Buckley. Now, I have to tell you, I've noticed something at NCQA, and that is everybody wants Brian in their meetings. And that's because every work group or project team wants to do right by health equity, and Brian is that collaborative, patient, and insightful colleague who is always there to help anybody do that. I'll let him tell you about the panel. Please welcome Brian Buckley.
Hello and welcome. Is everyone enjoying themselves? Yeah. So as Andy mentioned, my name is Dr. Brian Buckley. I use he, him pronouns, and I'm Director of Health Equity Initiatives for NCQA. And NCQA, for the folks that are also listening online as well, is the nation's leading evaluator of healthcare quality. And we are committed to ensuring equitable access to evidence-based, high-quality care for all individuals and communities. I support NCQA's health equity strategy across our organization. And as we talk about, we really need to infuse equity into every single thing that we do in our offerings. And I hope many of you have enjoyed many of the sessions here so far, that you have seen that evidence. But just to highlight a couple of things that we are doing. We are doing ongoing efforts to stratify HEDIS measures by demographics and understanding where there are gaps in care. Our new social needs measure, which aims to support healthcare initiatives to address the unmet needs for their patients through better screening, coordination with local and community-based resources. In addition to updating HEDIS to reflect gender-affirming measurement, because we should all be able to be treated with dignity and respect as we enter the healthcare ecosystem. And of course, you have heard many about our flagship programs, our Health Equity Accreditation and Health Equity Accreditation Plus program, which builds on our long-standing commitment for equity based out of our multicultural healthcare distinction work that we have done, which was built on the national class standards. Both of these programs lay the foundation for organizations to provide culturally sensitive care and delivery of high-quality healthcare. Today, I get the incredible privilege of moderating this incredible panel, No Quality Without Equity. Just to give you a little bit of backstory, the genesis of this session was driven by recent legislation developments in Florida, which had prompted several civil rights organizations to issue travel advisories for the state due to concerns about policies that impact healthcare equity. Let us be clear, we strongly disagree with the policies that undermine our mission and core belief that there is no quality without equity in healthcare. We are using this platform, which is being live streamed online and being available to share afterwards, to reaffirm that. We hope to see a future with better choices, better healthcare, and ultimately better health. We know that this is not possible without equity. One of my favorite quotes by William Deming is, "Every system is perfectly designed to get the results it gets." We know that historical and current policies, laws, regulations, and practices, they include and exclude people. This sets the stage for marginalization, oppression, and a lack of representation. Injustice is not new. Discrimination is not new. Resistance to positive change has always been with us. I'm referring to things such as the Charter for Professionalism established by the American Board of Internal Medicine in 2000. They discuss the fundamental principles, the principle of patient welfare, patient autonomy, and social justice as a foundation to medicine. Even further, the Institute of Medicine's 2001 report, Crossing the Quality Chasm, and we've heard many references to that throughout this conference, which includes 6 essential domains for high quality healthcare. that is safe, effective, timely, person-centered, efficient, and most importantly, equitable. This year marks also the 20th anniversary of the National Academy of Medicine's Unequal Treatment Report, which served as a catalyst for discussion and policy changes aimed at reducing healthcare disparities in the United States. These challenges require leadership and cross-sectional approach. Often many people have heard me talk about the Justice League of Health Equity, and I'm so happy to see so many of you here in this room and online that are part of that Justice League, knowing that we are all trying to advance equity because we all are trying to advance quality of healthcare. I look forward to bringing to the stage my wonderful panelists, which have shown in their work how they are leading with intentionality on advancing equity. So I would like to bring to the stage our panelists one by one. The first is Dr. Christopher King, Dean of the School of Health at Georgetown University. My next panelist, get there, round of applause, welcome them. Second panelist is Dr. Lydia Isaac, Vice President of Health Equity and Policy at the National Urban League. And last but not least, Nadine Smith, co-founder and CEO of Equality Florida. I encourage you to review their bios in the app and in the event website. My goal is to hopefully have a couple of questions at the end for this panel, so I'll make sure to let you guys know, but we have such a great panelist here, so we'll see how much we get through today. It's so fun. It's like, this is like my whole Justice League team right here. So often when I've talked about health equity, I've talked about really the 4 Ps of how we can think about how we advance equity, about perspectives, process, people, and projection. And so I'm gonna first start off with perspectives, and especially with the many different perspectives that my panelists bring. I always say we have to have a sense of humility on how we approach this work. So my first question, actually, the fact that we're in here in Florida, is to Nadine to actually share about what is happening in Florida and how you've worked across sectors to advance equity.
Sure, well, welcome to Florida. It's a very interesting time. I know for a lot of conferences, there are conversations about whether or not it's appropriate to come to a state where so many hostile pieces of legislation, where there's a general sense of restriction and suppression. I have a good friend who actually is doing another breakout group. And one of the things he said was, last year had I come to Florida, I wouldn't be facing this. But now, when I make a decision to use the restroom, I have to ask myself, the law tells me, despite everything about me and my appearance, that I must use the women's restroom, where I'm very likely to cause a commotion. But if I fail to, I risk going to prison. And so to invite people into a space that is so willing to restrict liberty and to impose draconian measures is a big challenge. And so I am grateful for the fact that there's a platform to talk about what has happened and what is happening in Florida and how it impacts health outcomes. And I think the most important thing to say is there is a general push to censor. So in schools, there are book bans, not just in one, K through third, but through the entire K through 12 system. And then within our universities, we have seen the uprooting of academic freedom, the entire turnover of leadership at a university to replace that leadership with people who will uphold this so-called war on woke. So we've entered a very Orwellian time where we're seeing censorship and surveillance. We are seeing the government interfering in the most basic medical decisions that parents have for their children and individuals have for their own bodies. We are seeing a kind of doublespeak. And what is unfortunate is that we all have a normalcy bias. We all think that at some point the guardrails of decency or democracy will take hold and the slide will stop. But unfortunately, we're living in a time where grievance and fear are easily weaponized. And Florida is the front line of an attack that is not restricted to our state. We are seeing parts of it happen in different places across the country, but Florida is where it's all happening. So it is whitewashing of our the curriculum in our schools. You know, they went from banning And Tango Makes Three, which is the true story of two male penguins raising an abandoned penguin chick in a New York zoo, to banning The Life and Times of Rosa Parks. You have, so we have been over the last 2.5 years watching while our governor talks about the free state of Florida, freedom's actually being restricted. While he campaigns on this sort of Orwellian message about liberty, seeing our liberties being taken away. That's the bad news. That's the environment that has caused people to ask, should we come to Florida? The good news I will leave you with in answer to this question is people are waking up and they're realizing that there aren't guardrails unless they become the guardrails. So when we launched something called Parenting with Pride, encouraging parents to actually show up at school board meetings and not allow, for example, there's one person using AI who has called for the banning of somewhere in the neighborhood of 20,000 books. And the law that passed in Florida allows anybody in this room, regardless of whether you're a Floridian, regardless of whether you have a child in the schools in Florida, you can call for the banning of a book in the state of Florida, and it has to go through a process that removes it from general circulation. So it's hard to fathom how draconian when you begin to hear about universities being told they must release private medical records because they want to identify who the transgender students are. You have to understand that they will test upon those they feel to be the politically weakest, the tools they will sharpen to use against everybody.
And we know that the aspects of policy influence how we live, as I was mentioning before. And so I want to shift to Lydia. The National Urban League, I know, has been doing a lot within the policy space, especially around health policy. You know, tell me a little bit more about how your organization is also looking at different perspectives and different populations.
So thank you, Nadine. Thank you for the work that you're doing. I think it's important for us to understand, the context that we're in. And so at the National Urban League, we're a historic civil rights organization that has fought for decades for the rights of Black Americans, but also particular vulnerable people or people who are marginalized. And, it seems like, I would say, the cliche thing to say, but we have to vote. We have really spent a lot of time focusing on voting rights for a reason, because we think about national, we think about, the president, but your state and local politics have so much impact on your daily life than who's president. And so, one of the things, for example, we did our national conference in Texas, which we know is the other guardrail that people have issue with. And we still went to Texas. There was these same kind of conversations happen. And our goal was, we can't abandon the people of Texas that need us. That's one. And secondly, one of the things that we did do during that time is Texas now has this thing where you have to register and be certified to register people to vote. We did certification trainings at our annual conference to make sure that people in our communities were certified to register to people to vote, so they could vote, to vote the people out who are not serving their best interests. And so, thank you. It's really important for us to remember the different aspects outside of health. And so I can't take credit for that. We have a wonderful social equitable justice team of strategic initiatives that has spent lots of time going around the country, going to battleground states, Georgia when things were happening, Texas, and making sure that we're reclaiming, we call our campaign Reclaim Your Vote, and that we're registering people to vote so that they can vote in their best interests, because we know people don't always vote in their best interest sometimes, but that they at least have the ability to go out there and vote for the person who can represent them the best. And so I think, all political decisions are based on the people we elect to make those decisions. And so making sure that we have the people who are representing us in those positions is the important part. So it's cliched, but I would say vote, 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 vote.
And so building actually off of both Nadine and Lydia around, one, making sure you're at the table, going to the school boards, making sure that you're voting, making sure that your voice is being heard. I'm going to turn to you, Christopher. Being at the intersection of all of that in health and being in the capital of DC at Georgetown, how are you thinking about raising the next generation of leaders in that space?
Well, thank you for that question. I'm telling you, this is going to be the fastest 45 minutes of our lives. There's a lot of energy and passion on this stage, and I just wish we had a lot more time. So I am at Georgetown. We just launched a brand new school, a school of health. And a lot of my work has been informed by community health needs assessments. I've been blessed to work with colleagues who've interviewed thousands and thousands of patients about their healthcare experiences. And this school is going to focus on the gap between what patients are experiencing and what we know is needed. And so we are thinking very differently around this work. For example, our nurses, our nursing students, medical students, health administration students, they go through these exercises to help them understand the relationship between redlining and readmissions, right? We do all kinds of interesting simulation exercises because we want our students to be able to connect the dots around why things look and are the way they are today. We're in the District of Columbia. There's so much history in that city. And so we have folks coming into the city and they're providing services. They don't know the history. And it's important that that story is told. Our patients have said, we feel rushed. We feel like we're not listened to. We feel like we're just another number trying to be pushed through the system. And that's a problem. And that's a quality issue, a lack of quality. And so it's a very different type of experience. Our programs are rooted in interdisciplinary practice. And we're not just talking about medical providers from different disciplines. We're talking about historians. What's the relationship between, in a community health needs assessment, we want historians to be a part of that to help providers understand the history of a community, and they can use their voices and their agency to advocate for changes in the infrastructure of a community that we know are important for healthy living.
Thank you for that, Christopher. I'm actually going to go a little bit further, especially given DC, and I know some of the work that you have done actually in really understanding that history within DC on how it has impacted health. And for many folks, if you look in the app, we talk about race, place, and structural racism and understanding a historical review of DC. What are the consequences when we don't talk about these policies and these political actions? How does that impact health?
We won't see change. We know that policies and practices got us here. Injustice got us here. Inequitable conditions got us here. And if that story is not told, we don't grow, we don't evolve, we don't learn, we don't do better. And so we believe that it's an important part of our mission to tell the story, the truth about our American history, because that information will allow providers to have a very different type of encounter with their patients. We take our board members into communities to learn about these social factors that are restricting healthy living. When they go back into the boardroom, they have a very different type of conversation around how do we rethink how we deliver care? How do we rethink how we organize, deliver, and pay for services to support holistic well-being? We call it Cure Personalis at Georgetown, care for the whole person. And so we're challenged to think about how do we rethink the delivery of care with an equity lens, with a racial justice lens, as a key component to a comprehensive population health strategy.
Love that. And so even and I love the Georgetown model of really understanding that history of how we actually got here. And Lydia, kind of shifting to you from, as you mentioned, NUL being a civil rights organization, especially around when it comes to Black health and racial equity for Black and brown folks, how do we think about people seeing themselves in healthcare? Actually seeing and feeling like they are treated with dignity and respect. How is NUL working in that space?
So I think it's important for us to remember that our patients are part of a community and they're a part of our communities. And really, we have sometimes this thing where we do drive-by healthcare, where we'll say, oh, you know, it's nice, I'm gonna visit the clinic, I'm gonna visit the school to see how people are. But understanding, getting the voices of the community into hospital settings, into healthcare organizations, into health plans, to understand the lived experience, but also the context that communities live in. And I think Christopher made a really great point about talking about the social injustices and the social determinants of health, and understanding my greatest thing when I talk to my colleagues is people's contexts. And the contexts are not siloed, they're not separate, they're interdisciplinary, they work together, they're not mutually exclusive. And so the contexts build on each other, right? And so if we don't understand the environmental context, the social context, the cultural context, we are in this wonderful, whether you want to call it gorgeous mosaic, melting pot, whatever you want to call this country, which is fantastic. But there is a context in how we do healthcare with different cultures, and understanding and being able to understand the communities you live in and the context that they're living in, what they're facing, is how we understand how to do quality better and understand our communities better. And so I think it's really important. What we really have, one of the great things about the National Urban League is that we have chapters all over the country, and they're local and they're based local. We help them with initiatives at the national level. We help support them, but they know their community. They are the trusted messengers, and that is why urban leagues across the country have been effective. We had great programs during COVID. We got hundreds of thousands of people vaccinated, and there's people who said we would not have gone anywhere but the Urban League. Why? Because they trusted the Urban League. They didn't trust their doctors. They actually trusted whoever we brought in, who were the same doctors, but because they were in our offices or they were in our parking lot, they came and they got vaccinated. And we were able to close that disparities gap because trusted people from the community were explaining what the vaccines were for, how they were worked, how they were saved, all those things. And so we do have to build better trust among communities and providers in order to provide quality care.
I love that, and especially building off a lot of the sessions that I got to get into around. Often we always talk about the data, and people are really focused on that, you know, quantitative data all the time, and we get into this data paralysis. And I love what you mentioned, and building on Christopher's work around how we also have to have community context and understand, what does the data actually mean? What is it telling us? Where are the gaps of how we're even asking or even approaching our communities? And so Nadine, you have also taken all of that in as we think about the qualitative and the quantitative. How do we actually integrate culturally competent care, especially as, you know, we're having talks about how do you collect and analyze SOGI data? How do you collect and analyze race and ethnicity data? How do you integrate that into the healthcare ecosystem, and what challenges are you seeing associated with that integration?
Well, I think one of the big challenges is trust, especially when you are in a state where state agencies are being weaponized against you, where you know, the Department of Education is greenlighting what are essentially, you know, the presidential politics of the governor. I mean, I want to make sure everybody's very clear about why we are in this moment, and I think the path out of it. I think why we're in this moment is there are quick, immediate benefits from appealing to people's fear. And there's a New York Times article, I'm quoted in it, but the most important part of the article is the conservative foundations who say this. They said, after marriage equality, we had lost that as a wedge issue. So we took everything, we threw it up against the wall to see what would stick. And what would stick is most people don't know trans people. And they said, and so we took that and we ran with it. And that is why, out of the clear blue, all of these more than 500 pieces of legislation, most of them targeting the trans community, suddenly fell out of the sky as the most important legislative agenda. Not because of actual issues that were arising, but because of the cynical effect of appealing to fear. And in our country right now, we are going through what demographer James Johnson calls the collision of the browning of America and the graying of America. And in that, there's a high level of social anxiety. What is my place? Is it slipping away? Does the future include me? And so there is a deep appeal to the idea of take America back to the day when I felt safe. Take America back to a time when things were more clearly defined in ways that protected me. And it is a short-term appeal with long-term harm, because the only way you get back to that place is to suppress and take away the freedoms and the liberty of other people. And so we are in this tension. And so when you say, how do you create cultural competency? How do you create an environment where LGBTQ people, for example, can trust that if I go to this medical place, the forms will reflect the fact that all marriages are not a man and a woman? How will I be certain that I can go to a place where the unique health issues, higher propensity for breast cancer, for example, among lesbians, is an understood thing that won't be missed because my healthcare provider never got that information? So to have those things and to have trust, you have to trust that the agencies that guide that also will not weaponize that information that is shared against you. So it has a very chilling effect to have the university system be pressed by the governor to release medical records. It is a very challenging thing to criminalize the conversations between doctors and patients, which is exactly what's happening in the state of Florida. The latest poll showed that 40% of parents of LGBTQ kids are contemplating leaving our state. So we have a challenge on the provider side. One, are they culturally competent? And then two, even the ones that want to be culturally competent, we have to trust not just them, but the system that they're in, that providing that information won't get weaponized. And then, the other way that this ends up, playing out in our lives we are losing talent from our state. We are losing medical professionals who have these skills because they're not being permitted to practice them. I remember I saw in Louisiana one of the only neonatal surgeons. He and his husband left the state because of the repressive laws being passed. And we saw that happen in Texas, and we know that a doctor out of Jacksonville, who's one of the only who can perform surgery, before the baby is born, left our state as well under the same kind of circumstances. So for us, we have to think of the entire continuum as a patient, as a provider. Are they culturally competent? And then do we trust the system in which they're working to be as honest as we need to in order to get the best kind of care?
I love what you said about the idea of trust. And this came up in some other panels, but really this idea of how are we as organizations being trustworthy? That action that we put that on us to actually showcase and prove that. But then also the aspect of people not seeing themselves in healthcare, which is its own danger, especially as I was talking about the different domains of what high quality healthcare is. It's person-centered. So I'm gonna ask Christopher, how do we actually, because you have talked about this also previously before, how do we actually create a system that is person-centered, that really creates that idea of humility, which you've talked a lot about, and trust?
So I've had the wonderful opportunity to participate and listen in on many of the sessions, and I'm hearing the word humility quite a bit, which is so affirming to me, because that is what we are focused on. We believe that humility is key. We're actually conducting critical audits of how we have taught students in the past. And we're conducting these audits again with an equity lens and with a racial justice lens. We have made a decision to not use the language cultural competency anymore. We are replacing it with humility. I remember years ago going to the mandatory cultural competency trainings right after unequal treatment.
Yeah.
And we were told, well, if you have this type of patient, then this is what you do. If you have this type of patient, this is what you do. And we thought we were doing the right thing as an industry, but we were doing more harm. And so humility challenges us to see each person as a unique individual with a very unique lived experience. And we believe that if we go into every medical encounter, if we create a culture that operates in a way that's rooted in humility, we will have a much more meaningful impact in the populations that we're serving. So that's important. And if you look at how folks have been trained, that has not been a part of the curriculum. And so what does that look like, right? What does it look like to show up in a community with humility? And part of it really challenges us to unlearn. Unlearning is part of the journey, right? And so for so long we were told, oh, well, we're going to do this for this community and we're going to call, the local news station and we're going to try and get some press because we're doing this for this particular side of town. And I remember when I was in my position as a VP of Community Health, I challenged our leadership and said, that's not what we're doing. We can't do that. The community is tired. This has been a form of exploitation. And if we're trying to gain trust, build trust, then we have to step back and recognize we don't have all the answers. The way that we can arrive at a solution is to listen to the individual in front of us. I've heard active listening quite a bit also over the past couple of days. Listen to the lived experience and meet people where they are. That's what I think is going to be monumental in helping us with this gap that we have between, the people just not trusting the health system. I also will share, I'll never forget this. I remember a patient said to us in a community health needs assessment, she said, I trust my doctor. I don't trust the institution of medicine. I don't trust the institution of healthcare. And so we're also focused on systemic bias. A lot of times we've gone through implicit bias, which focuses on the individual, which that's important work that we need to do. But we also need to recognize that systemic bias is live in the organizations in which we work in, we operate in the institutions that really shape society. And so this work requires intentionality. It requires us becoming comfortable being uncomfortable. It requires us to challenge the status quo. And it requires us to call people out when we see behaviors and actions that counter what we all believe in.
Thank you for that. I was talking to someone, they were talking about even community engagement, and they were like, I mentioned they always seem to go to the population in the community when something's going wrong, not necessarily building that trust and that ongoing relationship continuously when things are going right and things are going well. And so as we talk about building that communication and that trust and the relationship, Lydia, how do we build that trust with political leaders, which often do draft many of these policies that do impact not just, healthcare, but so many other aspects of wellness within communities?
So I always get this question, and I think it's very interesting. One, don't forget we elect our people who represent us. They work for us. I know they try to act like they don't, but they work for us. And you will not believe how many politicians, political leaders, representatives, state, local, national level, who say when they get a letter from one of their constituents, it means something. When you pick up the phone and call their offices, it means something. And I know a lot of us get those emails that are like, oh, sign here, call your representative. But if something is bothering you or something is not working in your favor, if they hear from 5 people, I guarantee you, I'm not saying they're going to change it, but they're going to listen. And one of the things we have to remember is, one, they're also human. They're people. They make mistakes also. I know we think because we elect them, they know all the information, but they don't. And sometimes it is about educating our representatives on what's going on, what the problem is, who are the people. We had a joke when I was teaching policy work for students that it's always the cat story that wins. And the reason why is that an academic can come and give somebody all the numbers, and then the grandma comes about her cat story with the firemen who helped get her cat out the tree, and the firehouse, I guarantee you, is gonna get the money. Why? Because the cat story resonated with your representatives, because they are human. And so one of the things we have to think about is, how do we tell the narrative of what's going on in our communities, and talking to our representatives in a way that the narrative hits home for them. They know this. They live, well, many of them live in the community and care. That's why they were elected. And so don't forget, after you vote for them, to keep in contact with them and hold them accountable. Don't just vote and say, oh, they're going to do the right thing because I voted for them. No, keep them accountable, talk to them, visit them, call them, send them a letter. They actually really do like to hear from people. And you're also allowed, not that everybody goes to DC, but they also have to be in their districts at certain times throughout the year. If you can't make it to DC and see them at their district offices. Those offices are usually empty, I guarantee you. And they are looking for people to come and represent and talk to them. So the really good ones, and that's most of them, I'm not gonna say bad things about most of the representatives, most of them did it for a reason, want to hear from their constituents. And hearing and understanding what's gonna help their constituents, I think is something that we don't do enough of. I don't do enough of it, I'm gonna say it myself. But every time I talk to a politician, they say, hey, I'm so happy to hear from you. I want to hear more stories like that.
I love that. And talking about stories, Nadine, we know healthcare is personal. There's an emotional aspect of healthcare. What is that story that needs to come out and be elevated as we are talking about all the different aspects of identity and the intersectionality of identities? How do we share those stories more broadly?
I mean, there's few places where you are as vulnerable as you are in a healthcare setting, whether you're in there incapacitated and at the mercy of the caregiver, or whether or not you are seeking treatment and in order to get the best treatment, you must be as transparent as possible. And it's difficult if you're wondering whether or not someone is going to take advantage of a new law in Florida that allows them to deny you healthcare based on conscience, vaguely defined. I know my wife years ago went to get health care, and after revealing that she was a lesbian, she found in the same envelope that had her prescription biblical tracts condemning homosexuality. Is she inclined to go back to that healthcare provider? But right now there's an atmosphere of such fear and such attack that I think there has to be proactive things that people do. I'll tell you, the hardest thing right now, being in Florida, is not that bad people are weaponizing fear for short-term political gain. It is that good people are afraid to stand up. It is the silence in places where people could have, not in huge dramatic fashion, taking the microphone at a town hall, but privately, in the realm where they have influence, say, that goes against our core values. Let's not go along with that. Let us speak up and speak out. Those are the moments. That's what everyone's looking to. What companies have rolled over out of fear of being attacked, and which ones have stood up and pushed back and said, those values are actually our values. They're not just marketing materials. We're going to be who we said we are. Which healthcare providers right now are reiterating their commitment to equity, to respect, to humility? Who is showing up in this moment will make a huge difference to how people will perceive. And so I want to encourage everybody here. There are moments of courage, and at the risk of sounding like Ted Lasso, I think the antidote to fear is curiosity. To ask yourself, when did we become so fearful of our neighbors, and who benefits from encouraging that alienation, that separation? And then get curious about people. And so right now we are living in a time where, in Florida, where we need to see courage. And to people who live in other states, I would say one of the best ways to help us here in Florida is to be the beacon of what freedom, liberty, and equity actually look like in your state.
So as you see here, as we were talking, I opened up about leading with intentionality. Just amazing, panelists of walking us through how they are looking at different perspectives and coming to this work with humility. How are we building trust? Knowing that we all have blind spots and making sure that we're using our collective knowledge. The privileging with process that we've talked about, voting being very much a way that we can make sure that as laws are being drafted and regulations, that the community voice, the frontline patient's voice is in mind. And then we've also heard about the emotional toll that many of these policies can have on our communities, but also individually as a whole. And then the last, which people have heard me talk about, is projection. What's the story? And I think, Nadine, you summarized it so well. what's the story we're going to tell of ourselves of the future of how we are actually advancing health equity? But more importantly, and my challenge to everyone else, what's the story that people are going to talk about you and your organization? What are you doing at this time, this moment, to really truly advance health equity? And so I just want to say a thank you to my panelists. We will have time for a couple of questions. So if we have people that would like to ask questions, please head to the mic. I think we have time for maybe 1 or 2 questions. And just want to say thank you to my panelists for just such an amazing aspect of, and your work in leading and intentionality in this work.
Yeah. There's one over there.
So I think we can, oh, sorry. Blind spot here, see? Perspectives. So Mike over here.
Hey there. It's not a question. My name is Laura Martin. I'm here representing the Board of Directors of Positive Impact Health Centers based in Atlanta, Georgia. But more importantly, I am a Floridian. I was born about 30 minutes down I-4. My family still lives in Frostproof and Lake Wales and Winter Haven. My family came to Florida in a covered wagon. And I cannot adequately express my gratitude to the work that y'all do and to the fight that y'all are in. It directly impacts my family, my friends, a few of them, both in Florida and Georgia, have left the region, not only the states, but the region, to protect their trans children. I don't have children, so I stay. I work in public health emergencies. Now I work in public health equity. It is so
Difficult.
the challenge is so deep, and I know that y'all feel it, and I know that y'all experience it, particularly Nadine. On the dark days, on the difficult days, I hope that y'all can just remember this room, this space, this time, the people that you meet, the children, the faceless, nameless children that you're protecting actively. And again, the words are not coming. I'm not feeling very intelligent in this moment. But the gratitude that I have from the bottom of my feet to the top of my head is indescribable. And I just wanted and needed to share that with you. Because although I don't live in Florida, I'm here all the time. I'm in Georgia. But this is home. And I'm just so saddened by where we are, but am in the fight with y'all for where we're going.
Thank you.
So,
Thank you. Thank you. Listen, I really want to say thank you for that. I want to say thank you because it's sometimes easier to get very cerebral about what is happening. But there are thousands of families that are uprooting themselves, leaving their businesses and getting out of our state because they cannot keep their children safe here. That is a reality. But the thing that I remind myself of, because I'm 58 years old, and I remember when the lady who used to sell orange juice suddenly started calling gay people groomers, and Anita Bryant was being bankrolled by the moral majority, and that was at a time when their objection was not around abortion, it was about integrating of schools. So we see this cycle playing out again. And I think the thing that is so important for everybody to always remember is that backlash comes after great progress, and backlash is the moment where we come together, we link arms in dangerous times. We understand you cannot fight homophobia and transphobia without standing up against racism and standing up for bodily autonomy and standing up across these issues and linking arms. And what is going to happen is we have to think of this backlash, think of a slingshot. They've grabbed a hold of that slingshot and they're moving us backwards, they think. Backwards and stripping away these rights. But when we break their grip, That slingshot effect is going to propel us not just back to where we were when they attacked us, but into the future that every single one of us deserves to have. And we have to prepare, because there are people right now that we think of as being opposed to us who are in such a grip of fear. But we have to build a future that everybody has a stake in and get them to understand that we've got to build that future together. And so I appreciate you bringing emotion to this, because these are people's lives that have been turned upside down. And it's the thing that I wake up every morning knowing that Equality Florida, we are going to meet those folks on the ground at every city council, every school board meeting, every legislative session, until there is equality in this state.
Sadly, I would love to have taken more questions, but I want to let you know that our panelists will be here throughout the evening, so please do find them. They want to talk to you and share their knowledge of how they are leading with intentionality. I first want to say thank you, one, to the virtual audience that we can't see, but I also thank all of you here in this room and our panelists. And I just want everyone to give themselves a round of applause, because you are all change makers and health equity champions. And so with this, we will go to our next panel, and thank you so much for listening and coming to this session, and hope that you enjoy the rest of the conference.